It gives me great pleasure to introduce Nichole Paradis and Sheryl Goldberg. Nichole is the Associate Director for the Michigan Association for Infant Mental Health, also called MI-AIMH, and the incoming Interim Endorsement Director for the Alliance for the Advancement of Infant Mental Health, which you are going to hear more about in a little bit. Both positions involve promoting standards for workforce development in the infant family field in 21 states plus West Australia. That part must be fun. Nichole is endorsed by MI-AIMH as an infant mental health mentor, clinical. Nichole's training includes a BA in psychology and a master's in social work, both from the University of Michigan, and a graduate certificate in infant mental health from Wayne State University. Sheryl Goldberg is the Training Institute Coordinator and the Interim Executive Director for MI-AIMH. She is also in private practice, providing reflective supervision and consultation for professionals in several settings that serve very young children and their families. She's provided direct services, administrative supervision, and training for over 30 years to support competency in early childhood relationship-based work. She currently has significant responsibility for implementation in Michigan and other states related to MI-AIMH's competency-based endorsement process. She has contributed articles and other publications in the field of infant mental health. Sheryl has a master's in social work and is endorsed as an infant mental health mentor. So now please welcome Nichole and Sheryl to the podium.
Thank you for having us. I'm so excited to have you here and for us to be here at this important time in your organization's development. I want to have to ask Nichole to switch slides for me, so we'll try and do that in a way that makes sense. So the next slide, Nichole. What is infant mental health? I don't know. I mean, obviously you're here because you have some idea about that, but the trick is often figuring out how do you talk to other people about it. Have you ever been asked at a party or something, what is infant mental health? It's an odd kind of conversation that you have to have sometimes. So this is an obvious way that many people will think about it, and you'll even get jokes about that, won't you? You know, babies on the couch, yeah. So I might say babies on the couch with their parents and with me. So next slide. So I want to spend just a little bit of time sharing with you our thoughts about what we mean when we talk about infant mental health. We consider infant mental health to be an interdisciplinary field, not just mental health. And we're concerned, all of us, with the mental status and well-being of infants, toddlers, very young children, and their families. Our next few slides will talk about what we mean a little bit more specifically in terms of principles, infant mental health informed, work with families, and then infant mental health practice. Next slide. Okay, so principles. We do have theoretical foundations and assumptions and values that guide our understanding about what infants and toddlers need. Some of these examples are on the slides here. Attachment, family systems, being trauma-informed, but we really assume that babies do not exist alone, right? Like Winnicott talks about, there's no such thing as just a baby. We also really believe that the earliest experiences that a family has during pregnancy and through the first few years of life will lay the future for, lay the foundation for future development, and that is not something that everybody automatically believes. And now we have some more science to support that. And relationships obviously are critical, given that, to support babies, and that's the best way to do that, including supporting their families and to strengthen and build their own relationships. Our relationship is important with the families. And then this last item, really, ghosts and angels, is something that we have pulled from Selma Freiberg. Is everybody familiar with that term, the ghosts in the nursery? Raise your hand if you are. Okay, many, most of you. So Selma Freiberg and her colleagues in 1975 introducced that metaphor, ghosts in the nursery, to describe the ways in which parents by reenacting with their small children scenes from the parents' own unremembered past and their early relational experiences of being helpless, perhaps, and were transmitted to the next generation. So, in other words, the ghost represents unresolved losses, separations, traumas, and those things can get in the way of them providing nurturing and sensitive care to their infant. And so the work in infant mental health, according to Selma Freiberg, centered on helping families identify those ghosts so they could be banished from the nursery and separated out from the way that the parents felt about that particular baby and behaved towards their baby. And then, a little bit over time, Alicia Lieberman coined the term angels in the nursery. She was a student of Selma Freiberg, and that was used to describe those people who were there to support the healthiest relationships for the baby, where the baby felt truly understood, cared for, accepted, and loved, and gave that core sense of security and self-worth. And so we in infant mental health really believe that uncovering those angels as growth-producing forces when we're working with families is crucial and vital to the work of the psychotherapy, and just as vital as interpretation and exercising of the ghosts. Next slide. So not everybody will be doing that particular aspect of the work, but we do want everyone who comes into contact with the life of an infant toddler to be infant mental health informed. And what that means is to really work from the perspective of respect for relationships, sensitivity to cultural issues, recognition of that first 3 years as both a window of vulnerability and a window of opportunity. And to have some knowledge that there will be, for many of the families who come into our lives as professionals, there will be ghosts that are also there that might be present. And even though it's not, might not be your role as an infant mental health professional to address those ghosts with the parents, that awareness is helpful. And it can create empathy in your work for the parents who may otherwise arouse feelings of anger, resentment, disappointment. Certainly can be challenging sometimes. So infant mental health work can really apply, and infant mental health informed work can really apply to all of these disciplines and that you see on this slide, and up to the level of macro involvement. And the next slide, my dear. So infant mental health practices. While the infant mental health informed work is desired for anyone who touches the lives of infant toddlers and families, infant mental health practice is really referring more specifically to intervention. Professionals from a variety of disciplines, not only licensed mental health professionals, may practice infant mental health. However, that practitioner will have received the specialized infant mental health training necessary to provide this level of intervention and receive reflective supervision while they're doing it from a qualified professional related to that intervention. So the work in the practice will include these things typically that are in the infant mental health home visiting model that we have in Michigan: case management, advocacy, emotional support, developmental guidance, early relationship assessment, social support, and then parent-infant, very young child relationship-based therapies and practices. Nice long word. So the work on those unresolved losses does not have to be explicit really with every family, it depends. However, the applicant, when we're talking about endorsement, has to have had some of the specialized training and reflective supervision that prepares them to work in that way when it's appropriate. And that would be more specifically to level 3. We'll talk a little bit more about that later. Infant mental health practice can be conducted in homes, it can be conducted in clinics, it can be conducted in other settings. And again, we know that we have to be open to looking for what the ghosts might be that are interfering with this development, the healthy development of a relationship. And the ghosts could be way from the past of the parent. They could be more reflective of a difficult beginning with this particular child, and or it could be something that is related to an ongoing disability or delay that the infant or toddler has. Next slide. So I was asked to talk just a little bit about reflective supervision consultation. And we use both supervision and consultation when we talk about it because of some of the different labels that people need to use with regards to what is called supervision or what is called consultation. But generally, when we're talking about the reflective supervision consultation, these are the things that we're talking about here. I think there are a lot of aspects to good clinical supervision that are part of reflective supervision, but reflective supervision consultation is distinct because of the shared exploration of that parallel process. And what we mean by that is the attention to all of the relationships, including the ones between the practitioner and supervisor, between the practitioner and the parent or caregiver, and between the parent and the infant or toddler. And it's crucial to understand how each of these relationships affects the others. Additionally, reflective supervision and consultation relates to the professional and personal development within one's discipline by attending to emotional content of the work and how reactions to that content affect your work. And then finally, there's often greater emphasis on the supervisor and consultant's ability to listen and wait versus giving direction and allowing that supervisee to discover solutions, concepts, and perceptions on his or her own without interruption. So you can see that there are several elements that would apply to supervision that you are familiar with, and then there may be some that are different. I have a few quotes on the next slide to share with you. When people hear about this sometimes, it's not uncommon to hear the concerns that this is like therapy. While the reflective supervision can be therapeutic, it is not therapy. It's intended to enhance self-awareness and personal development, but only as it relates to the work. And, you know, we're human beings, and obviously we have relationships of our own, we have ghosts of our own, we have angels of our own, we have cultural assumptions and backgrounds of our own, and we must be paying attention to who we are and what we bring to those relationships when we're sitting and working with the family where we have concerns. So I think another really important thing about reflective supervision, which is also reflected in these quotes, is that it really should reduce the feelings of isolation that practitioners can experience. Witnessing very vulnerable infants and children living in risky environments is a burden. Having a place with whom you can share those burdens can help the practitioner to lighten their load and feel less alone in the work. And therefore, it's a strategy really to help manage compassion fatigue, secondary traumatization, and to support retention of workers. It provides also a space to really do the ongoing assessment that we know is important to our work of the child and family, so that the intervention and treatment plan can be revised as needed and as new understandings emerge. If a program supervisor also has the responsibilities to do clinical or administrative supervision, then careful attention has to be paid as to how to incorporate the reflective component that we're talking about. We can talk more about that as we work together with your group here about what you are trying to do, as well as some of the other solutions that are out there. Okay, Nichole, next slide. there's a little bit of evaluation going on right now about reflective supervision. Sometimes it's harder to have support for that by funders, and therefore it becomes important to say this is part of professional development, and it's effective in creating good working relationships and good outcomes for families. But one of those things that we're trying to do first is to really identify and validate all of the essential elements and skills that could be observed in a good reflective supervisory session. And so you can see that there is work going on by the research committee of the League of States, which are the endorsement leaders in each of the states, including you. There's a research subcommittee that is looking at the scale developed by University of Minnesota, and we're working on that, and it's called the RIOS. So there is a publication that's out there. You can see me if you would like a copy of that, but I think the citation's right here for you. Also, we have some efficacy scales that are really self-assessment scales that we've been using in Michigan for supervisors and supervisees, and those are being used in several research projects in Michigan and elsewhere. Now, specific to endorsement, on the next slide, relationship-focused, reflective supervision and consultation with an approved supervisor and consultant, individually or in a group, while providing services to infants, toddlers, and families, is what we're talking about here. So, you can see for the different levels what the minimum number of clock hours are, and what we mean by the time frame is so you have an assurance that there's enough frequency in the meeting that you can maintain a relationship that can be used for learning and growth. So we don't want this to be stretched out for a huge amount of time. In Michigan now, we've been around long enough and have enough reflective supervisors who are endorsed at level 4 clinical or at level 3 that we can require that all of the reflective supervision tool that goes toward endorsement be provided by one of those. But in newer league states, we're building capacity for reflective supervision. Approved providers are those who either are endorsed or they might meet criteria. And those have to be vetted by your particular mental health association. So the FAN model that I know is being used by nurse family practitioners here it was developed by Linda Gilkerson at the Erickson Institute should be something that would definitely be useful towards that. I'm going to turn this over to Nichole now, and we'll switch.
All right, we're going to talk now more specifically about what are these competency guidelines that you all have adopted. One of the things I think that might make our set of competencies a bit unique is that it really is based on a multidisciplinary framework. There isn't an assumption that only licensed mental health professionals are the only ones who practice or work from an infant mental health informed perspective, but that it truly is cross-disciplinary. So it's creating a shared framework across the infant and family field to promote high-quality, relationship-focused practice and social and emotional health beginning in pregnancy and including in the first years of life. It's set up to guide development of knowledge, skills, and best practices across systems and across services to all infants, very young children, and their families. So again, it's a sort of set of standards. What do we mean by best practice, and what does that actually look like depending on what your role might be working with the family? The standards can be built upon over the course of someone's career. So in Michigan, we have a large number of people who may start at endorsement as level 1 and then move to level 2. Later they may move to level 3, and eventually they may even move to level 4. And it provides sort of a path for folks who are interested in taking on different kinds of roles in an infant mental health field. If I want to move from being an infant family specialist to being an infant mental health specialist, what does that mean? What skills, what knowledge, what experiences do I need to add to what I already have in order to make that professional jump? And this is a map for doing that. The standards, sorry, I lost my place for a second. Oh, so the strengthening the scholarship for the promotion of infant mental health. When we all have a common set of standards to work from, evaluation is much easier to do. And as we've mentioned several times, there are now, by the end of 2015, there will be 21 states in the United States who are using this set of standards, and that doesn't include West Australia. So the fifth one there is to invite dialogue for collaborative practice, training, and professional growth. And this meeting here today is a perfect example of that. You have folks here representing all different disciplines, all different systems, all who share that common desire to be helpful to infants, toddlers, and their families. And so this framework, because it is interdisciplinary, because it can be used across systems, helps to bring all those people together, literally to be in the same room. And we believe that these standards promote systems growth and change. And we've got some examples of that on some later slides that you'll see how people in other states, other infant mental health associations are using these standards to really make big changes in their states. Some small changes too, but they're meaningful. All right. So now I'm going to talk a little bit about the history of how these guidelines were developed. We want to make sure that people understand there weren't, 4 people who said, I think this is what best practice is, and I'm going to write it down, and therefore what I say goes. This was developed very thoughtfully over a period of approximately 8 years that involved input from across all the disciplines that we've been talking about, and from literally hundreds of people. People kept work diaries, people looked at other training guidelines. This was a very thoughtful and long process. So it started, as we say here, in the 1970s. We talked a little bit about Selma Freiberg. Michigan likes to pretend like we own Selma Freiberg because she got her MSW from Wayne State University, and she did a lot of her work at the University of Michigan. But really, her coining the term infant mental health and the work that she did sparked something big in Michigan. It caught the attention of a woman whose name is Betty Tableman, who at that time had some responsibility at the Department of Community Mental Health in the prevention services. She heard about what Selma Freiberg and her colleagues were doing, and she got very excited about what that could mean in terms of as a prevention service for troubled families. So she met with Selma Freiberg, and they developed an agreement to train practitioners in this particular field. It was sort of a train the trainers group that then went around the state of Michigan and trained practitioners in every area of the state. Betty Tableman also went on to ensure that there was funding for infant mental health home visiting services that followed the Freiberg model. So there are practitioners in every county in the state of Michigan who are required to be using the infant mental health home visiting model based on Freiberg's work. And we'll talk a little bit later, those folks are also now required to be endorsed in order to have Medicaid reimbursement. So we'll talk about that a little later. All right, next slide, Sheryl. So by 1986, the Michigan Department of Education became the lead agency for what was at that time Part H services. Now we know them as Part C services. And as a part of their workforce development plan, they, in Michigan, which by the way, the committee included a lot of folks who happened to be MI-AIMH members, and they set out to identify these core competency domains: the theoretical foundations, legal and ethical foundations, interpersonal team skills, direct service skills, and advocacy skills. And we just kept building on the work that was being done over time. So in 1986, MI-AIMH approved a 2-page document called Training Guidelines, and this was based on that agreement between Betty Tableman and Selma Freiberg about, okay, how do you train people to do this particular kind of work? So this is the document that was a result of that. Then in 1990, 0 to 3, and I don't think they were even called 0 to 3 at that time, but we now know them as 0 to 3, published a document, task documents, which also sort of outlined what were some of the training and experiential needs of people who were practicing in infant mental health. Then, by 1997, MI-AIMH came together, and a part of what sparked the next steps were in part this desire to sort of say, okay, who gets to call themselves an infant mental health professional? Can anybody just go into a courtroom and tell a judge, I know about attachment, ask me, I can tell you what this baby needs? Or should there be a set of standards that define who really does understand this, who is qualified to speak up on behalf of babies and families? So as a desire to sort of make that clearer came about, MI-AIMH came together and they expanded on those 5 domains that were originally identified as a part of the Part C work plan, and they added these 3 domains: systems expertise, thinking, and reflection. Then we get to the year 2000. These things happen slowly over time, as I'm sure you all know. And in the year 2000, MI-AIMH received a grant from the W.K. Kellogg Foundation, and that allowed MI-AIMH to hire an executive director and an administrative assistant, which enabled then the completion of the competency guidelines, put into a document, printed and published. And then the final phase of that particular plan was then how do we use these competency guidelines to really promote a professional development system? So then we get to the endorsement. It's called an endorsement, and it's important to make that distinction. It's not a license, it's not a credential, it's meant to be an overlay on top of whatever your discipline's requirements are in terms of licensing. But it also can provide for folks who are infant mental health informed practitioners who may not be governed by a license otherwise. They can also apply for endorsement as a way to sort of demonstrate their professional commitment to the field. I also want to make sure it's really clear, because often when we go places, and still in Michigan, it can be confusing to folks. Folks may call up and say, I really am interested in this field of infant mental health. I'd like to be endorsed so I can go out there and do the work. And we always have to kind of back people up a little bit. Endorsement is the recognition for having done the work, received some training, received some specialized reflective supervision. It's the acknowledgement that you've already developed this sort of specialization. It's not a training series that you go to and you receive a certificate when you leave. We're very fond of saying that there are multiple paths to competency. No 2 endorsed people will have reached endorsement through the same path. They will have had different kinds of work experiences. They will have different kinds of training experiences and different kinds of educational experiences. They all hopefully get to the same place at the end of that map, but they may get there in very, very different ways. Okay, so there are 4 levels to endorsement, and you've heard us kind of refer to them a little bit earlier, but level 1 is infant family associate. Level 2 is infant family specialist. Level 3, infant mental health specialist. And level 4 is infant mental health mentor. Now, after endorsement was launched in Michigan, we recognized that there was a need to expand level 4 to really acknowledge the different kinds of mentors that exist who've sort of made infant mental health services possible. So the 3 designations are clinical, and at level 4, that's for folks who are providers of reflective supervision and consultation to other practitioners. There is policy for the folks who, like we were talking about Betty Tableman, and that there are people in this room who are responsible for writing policy that ensures that services are available to infants, toddlers, and families. And there are people who advocate at a legislative level for those services to continue to be funded. And then research faculty is about what it sounds like, folks in academic settings who have responsibility for conducting research and or teaching folks about infant mental health. So now we're going to look at a little side-by-side comparison. And if it's difficult for you to read, I think there's a larger handout in your packets that show this side-by-side comparison of the 4 levels. One of the things that I think is always important for me to point out, when you look at this initially, especially with education as the top row, it can be really easy to try to categorize endorsement in your mind as, oh, I see, level 1 is associate's degree, level 2 is bachelor's, level 3 is master's, and level 4 is beyond master's. It's not that straightforward. It's really much more about the second row down, which is about the specialized work experience. How is it that you are working with families? What is your role? What type of program do you work in? Are you doing promotion, prevention, intervention, some combination of those things? So that's really the more specific category in terms of determining where you might fit in or where an individual might fit in terms of endorsement. The other thing it's really important for me to say here is that the detail that talks about those differences doesn't appear in this little tight chart. When you want to look at the detail about really what are the requirements in terms of work experience, I encourage you to look at that booklet and turn to the page that has the requirements spelled out much more clearly at each level. But in general, level 1 has been, at least through our experience, primarily folks who come from early care and education backgrounds. So lead infant teachers, early Head Start teachers, other folks who've pursued some infant mental health informed training and have some hands-on experience with infants and toddlers and want to demonstrate their commitment to this knowledge around infant mental health. Level 1 does not require reflective supervision or consultation. We do recommend it for everyone, but it's not required at level 1. I will say level 1 has also been a great place for others to start. For those people who I'm really excited about infant mental health, I took some courses in graduate school, I've been to some training sponsored by my Infant Mental Health Association, but I haven't yet had any work experience in infant mental health. Therefore, also haven't had any reflective supervision about my work in infant mental health. So for those folks, they've sometimes begun at level 1 to demonstrate a commitment to the competencies, and then they go on to find work that then does help them qualify for endorsement at other levels. Infant Family Specialist is level 2. Those are folks who are bachelor's or master's prepared. In Michigan, we have the vast majority of people who are endorsed at level 2 are master's prepared. But they all tend to be folks who come from home visiting programs, from early intervention programs. In Michigan, we don't have as many Nurse-Family Partnership or Healthy Family America programs, but with the expansion of MI-AIMH, we have more now than we had before. But in those kinds of home visiting programs, those are often the folks who would be appropriate for the Infant Family Specialist level 2. Then we get to level 3, Infant Mental Health Specialist. And as Sheryl was talking in an earlier slide about infant mental health practice, it's those folks who really are working in a program or in a system where they have both the training, the expectation, the supervision, and sort of the programmatic permission to be providing those relationship-based therapies and practices. So things like parent-infant psychotherapy, child-parent psychotherapy, places where, and families where thinking about the ghosts in the nursery is what's most appropriate. It's not necessary for someone to be a licensed mental health professional to earn level 3, but we do acknowledge that as licensing requirements have changed since endorsement was launched, especially at least in Michigan, it's very difficult to find work that meets the criteria for level 3 if you're not a licensed mental health professional. It's not always the case, it's just often the case. And then level 4, we talked a little bit about that already. There tend to be the folks who are infant mental health leaders in their community. So in addition to either being someone who provides reflective supervision to others or someone who has policy or programmatic leadership responsibilities, they also have to demonstrate that they are practice leaders in their community. So these are people who also are helping by volunteering through their Infant Mental Health Association. They are parts of committees that put on conferences, that bring trainers in, that write about infant mental health and publish about infant mental health, who mentor other people who are interested in wanting to come up and come along in terms of infant mental health. So that's part of the requirement at level 4 as well. One of the things I also want to remember to say, the competencies themselves are really designed for people who work with pregnancy through age 5, kiddos and families through that whole age range. However, at the moment when we talk about endorsement, the criteria has to be work experience with 0 to 3. At level 2, we even say there's a minimum number of families. So, for instance, in Michigan, we have a lot of home-based folks who work with families 0 to 6. those folks have to document that they've worked with a minimum of 10 families where an infant or toddler was the primary target of their intervention and not just the little sibling of the 5-year-old who they really are working with. There is some hope that as the Alliance and the League become stronger, that we'll be able to expand this criteria, that it will eventually be birth to 5 rather than just birth to 3. But at the moment, folks whose work experience has exclusively been with preschoolers may not meet the criteria for endorsement as it's written at this time. Does anybody have, well, we're going to take questions of me. All right. Okay, we're going to just talk for a few minutes. I'm going to turn it over to Sheryl in a minute to talk about the structure of the competency guidelines. But I just want to remind you of what the 8 domains are. And these domains appear at every level. The domains include theoretical foundations, law, regulation, and agency policy, systems expertise, direct service skills, working with others, communicating, thinking, and reflection. Now, those domains appear at every level, but the knowledge and skill areas that appear at the levels may vary from level to level. And also the criteria when you're looking at the detail in that competency guideline booklet, the as demonstrated by may change from level to level. So there may be, for instance, disorders of infancy and early childhood is something that's required at both level 2 and level 3, but the level at which someone is to understand disorders of infancy and early childhood would be, less sophisticated knowledge would be required at level 2 than would be required at level 3, for instance. You see here that attachment, separation, trauma, grief, and loss is pretty critical and is required at all 4 levels. We just talked about disorders of infancy and early childhood. It's not required at all for level 1, but is for the other levels. And then parent, infant, very young child, relationship-based therapies and practices are required at level 3 and level 4 clinical, but not required for level 1 or for level 2. Okay, I'm going to have Sheryl's going to, there are sort of 3 big domains of competency. Not that they're not all important and not that they're not all required, but sometimes it's hard to look at all 8 of them in detail. So we picked the 3 that we tend to look at most closely when we're reviewing endorsement applications. And Sheryl's going to kind of walk you through some more detail on those 3.
Okay, so the first main area that we look at in terms of competency in endorsement is theoretical foundations. So we need people to know some things, right? I mean, when I was a direct service provider at a community mental health agency in Michigan, they pretty quickly shifted so that if you were a social worker, you could do just about anything within the agency. We all who are doing practice kind of know that's not true, right? So we really felt, again, as Nichole had said earlier, that when you're doing the work with families at this time in their lives, with little children, you really need to understand, no matter what your profession or your setting is, what it means to do the work with that particular population. And so we feel that pregnancy and early parenthood, both what is normal development during that time, what are issues that might come up, red flags that you need to be paying attention to, and best practices to support families in moving through that phase, and resources that you might want to connect them to if needed. For example, if you are not in a mental health profession, but you're really concerned about postpartum depression, for example, or what looks like a difficult adjustment for a family, how do you help a family at that time and within your role, and also connect them with resources that they might need. Infant and very young child development and behavior, of course, is going to be important, and we're not just talking about social and emotional development, but that's often one that's quite overlooked, and so that is important. And we're talking about typical and atypical. What are some of the things you need to worry about? How do you know when it's going well? Attachment is part of that, but there's also quite a bit more. And how those domains interface with each other and support or hinder each other when there may be a particular delay in one area of development. How can that affect the progression in other ways. So if you have a mobile baby, that's going to allow them to explore, right? If you've got a baby who is hindered in their mobility, how will that impact them when they're moving toward that stage where they could be exploring the world? And how will that impact the parent if they're concerned about their baby's ability to do that? Infant family-centered practice refers to the relational context and development and the importance of family-centered work, as we know in Part C, but also for the relationship itself. And then the relationship-based therapeutic practice is really paying attention to the working relationship that you bring, as well as the relationships that exist for the child, the family, and those around them that are important. And again, that moves also into family relationships and dynamics. There are a lot of things that happen at that time in life that people need to understand. Attachment, separation, trauma, grief, and loss. It's a big category, and we're talking about typical development. We're talking about the kinds of things that can impact, including ghosts, including other stressors, including trauma, including loss, and the grief process that might be related to all sorts of issues, either in past or present situations. Disorders of infancy and early childhood, that again, as Nichole said, we need to, as practitioners, recognize when there may be a concern, and then if you are a clinician who has responsibilities to diagnose, then you obviously have to have that level of skill as well. Cultural competence is obviously something that needs to be an area where we need to be able to function well, no matter what your background is, no matter what your practice setting is. And then the ones that are not bolded are reflective of what a level 3 or 4 practitioner needs to have. That is not required for level 1 or 2, and that is psychotherapeutic and behavioral theories of change, and then mental and behavioral disorders in adults, where we're really talking about working with families where there are significant challenges because of the parent's mental health status. Direct service skills is the next important area. Everybody needs the skills at whatever their particular level is within direct service skills that are bolded. Observation and listening, that's a key piece of understanding what is happening with children. So it's not just a tool, right? We know that just whatever your score is on a Bailey or on ASQ is not going to tell you everything about what's happening for that baby or that family. And so observation becomes really important. It is a key skill. And we do quite a bit of training in that, as well as listening. What are the stories being told to us, whether we're paying attention to them as directly reflecting what's happening with the family, or maybe it's a story about something that a neighbor has experienced. Is there a message there for us? Screening and assessment, again, there are a variety of tools, and we all have our tools that we're required to use, as well as the whole piece of informal assessment and informal evaluations. Responding with empathy, advocacy, life skills and safety, those are all things that we need to know when we're working with families. And then the unbolded items we're talking about are, again, reflective of what is required for level 3 and 4. Intervention and treatment planning that builds upon what we've already talked about so far this morning. Those are going to be required, obviously, in terms of your setting of a particular treatment plan and guiding your intervention toward a family's ability to be reflective, a family's ability to understand and to interact. When we talk about developmental guidance, it's another specific strategy related to some of Freiberg's model, and I know that everybody will do developmental guidance of some nature, no matter whether you're level 3 or not, but this is specifically referring to some of the non-didactic developmental guidance strategies that we hope that mental health clinicians will have. Supportive counseling, again, a specific strategy, but it's also something that we're going to expect a lot of other folks to be doing. However, it is one of the particular strategies in the infant mental health model. And then parent-infant, very young child relationship-based therapies and practices refers to, as Nichole said, parent-infant psychotherapy, child-parent psychotherapy, interaction guidance, and some of the other things where the port of entry may not be on the reflective or functioning or subjective experience of the parent, but more on an interactional, in the moment kind of thing that is, again, intended to really address what are the barriers to healthy social and emotional growth within that relationship. Then the next primary area is reflection. We want people to be able to think, really not just move right in and act, but to really think about what might be happening in this family, what might be making it so that this baby's cries are not being heard or responded to by the parent. What might be going on? I want people to think before they move. I think Sheryl, who's one of those folks who's also trained with Freiberg, talked about sit on your mouth. A hard thing to do sometimes, because when we're there in the moment and we have reactions, emotional reactions, and we see things that we're worried about, there are risks that we see sometimes. And there could be lots of things that are happening for us in our heads and in our hearts when we're working with at-risk children and families. And we want to do something. We want to be helpful. So sometimes we move too quickly. So think first, really, and think on an ongoing basis. And continue to evaluate, what am I seeing, what am I hearing, and what am I thinking about doing. Self-awareness obviously becomes a part of that, to be able to pay attention to not just what are you seeing and hearing and thinking, but what's happening to me in this whole process? What do I want to do? And is that really based on what's needed? Is it based from some of my own ghosts? Is this something that I should be paying closer attention to? What's happening in my working relationship? Is this a parent I'm having a hard time dealing with? Is this a child I want to take home? So being able to really think about yourself and acknowledge that you are bringing something to this dynamic that needs to be paid attention to in order to be effective is really key. Curiosity is not that different than contemplation, except I think to me it means really that openness, of an attitude of wondering. We wonder, we need to wonder a lot and not just move to assumptions about what might be happening here right away. And again, professional and personal development. If you're doing these things, if you're allowing yourself to use this, the reflective supervision relationship, your working relationships with families, you are going to grow. And it's a stance of being open. It's a stance of letting yourself be changed by what you're experiencing, and the wish to move forward and learn more. Are you pursuing training? Are you pursuing and really engaging in your reflective supervision? Emotional response, and that is allowing yourself to feel, allowing yourself to be responsive to the emotion that's being brought, expressed in one way or another in your work, in families work with you. Can you manage that and not just be task focused? And then parallel process, Again, that one, we're not expecting that someone at level 2 or 1 would be intimately able to articulate, but we are expecting that at level 3 and 4. Can you really pay attention to the effect of relationship upon relationship? Can you work with that? Can that inform your work?
So I want to talk a little bit in more particular about this League of States. And it's a term that we coined ourselves. We just couldn't think of a better way to sort of talk about the group of states who, like Washington, have an infant mental health association who purchased a license to use this set of competency guidelines and in most cases also implement an endorsement system. Let's see. These associations that are on this map, almost all of them are affiliates of the World Association for Infant Mental Health. Those that aren't yet affiliates are working toward becoming affiliates. Some of them are brand new associations that there were people in the state who were excited about infant mental health, who wanted to bring the competencies and endorsement there, and actually formed an infant mental health association in order to make that possible. The endorsement license can only be purchased by statewide infant mental health associations. So local governments can't endorse professionals, universities can't use the system to endorse professionals, only infant mental health associations can. So that's why some of them aren't yet affiliates of WA-AIMH, because they're pretty new. Now you see on the map there, Florida is in purple. I just came from Tampa 2 weeks ago where they were telling me, we're always different, we're always the different one. Florida is different from everybody else. Florida is unique in that the Florida Association for Infant Mental Health has not yet purchased a license to use the competencies or the endorsement, although it's something that they're thinking about. But in Florida, there are 2 children's services agencies, one in Palm Beach County and one in Hillsborough County, which is where Tampa is. They've purchased just the competencies and they use them to guide their professional development plans for the staff and the programs that they fund there. They're very interested in bringing endorsement there, but they don't have it yet, and that's what makes Florida different. I mentioned that by the end of this year, we expect there to be 21 states in addition to West Australia who are sort of a part of this league, and it's growing all the time. We know of 3 other states, Hawaii, no, more than that, Hawaii, Pennsylvania, Massachusetts, and Arkansas are all considering joining by 2016. So I think the momentum is building, growth is happening rapidly. So due to this rapid growth, we've moved from what has been up until now a very grassroots association in terms of the League of States. That there's been a written agreement across the league that respects reciprocity of endorsement across the states. So if you earn your endorsement in Arizona and you move to Washington, your endorsement would be transferred and would mean the same thing from state to state as long as it's the same set of competencies and endorsement system. So in order for there to be meaningful reciprocity across these states, we communicate with one another regularly to try to be sure that we're all implementing endorsement in the same way, that we're all providing quality, competency-based in-service training to members, and that we're reviewing the exams, that we're reviewing the applications consistently, so that the reciprocity means something from state to state. Because the growth has been so rapid, in Michigan, sometimes I feel like we feel like we're really mighty because our association's been around for 38 years and we have 800 members, and so we feel like we kind of are established. But in terms of the central office and the work that we do, we really only have 4 staff, and most of them are part-time. So it's been very difficult to keep up with what the folks in Michigan need that we've always provided to them in terms of membership benefits, a newsletter, the conference, training, endorsement, and to still respond to these requests to help grow the competencies and the endorsement in other states. So we're finding ourselves stretched thinner and thinner and thinner. And so the Michigan Association for Infant Mental Health's Board of Directors made a decision that MI-AIMH is now going to be, we're in the transition officially of splitting into 2 organizations. There will be the Alliance for the Advancement for Infant Mental Health, and that organization will be responsible for all of the national and international activity related to the competencies, related to endorsement, support for all of the lead states to do what they need to do and to grow and to sustain their efforts. And then the other things that have traditionally been MI-AIMH activities that are going sort of with the Alliance, coming with the Alliance, would be the Infant Mental Health Journal. I don't know if many of you subscribe to that journal, but it's owned by MI-AIMH and will be going with the Alliance. If you're not a subscriber, it's $40 a year. If you're a WA-AIMH member, and it's a really good peer-reviewed journal, I recommend it. It's now available online, which means you can have access to all the articles in the past. It's a great journal, and we thought moving it with the Alliance would give us an opportunity to promote it, make more people aware of it. The other thing that will be coming with the Alliance is, in the world of evidence-based, the Michigan model that we were talking about this morning, that Selma Freiberg and Betty Tableman were responsible for founding and strengthening in all counties across Michigan in the community mental health system. It's a promising practice, but it's not yet been established as an evidence-based practice. The work on that has started as of this year, and so we hope to get to evidence-based status within 5 years. But doing that, it's being called early attachments, by the way, and once that model has been established as an evidence-based practice, it's our hope then that other states and other communities could adopt that as a way to expand service delivery systems where they are. Right now, a lot of the evidence-based practices that are being funded through the Affordable Care Act, through the McV funding, are fantastic programs, and they're benefiting thousands of families. But they don't always have the capacity to address the very severe risks that we know many of our families come in with. So, there might be a Healthy Families America home visitor who's been going out, providing terrific support to the family, but I think we've all had the experience that the more you get to know the family, the more sort of the curtain gets pulled back, and you get to see more and more of the worry and the risk that exist for that family. And we want there to be a program that is prepared to help families with that level of risk, if it's more than, say, a Healthy Families America or a Early Head Start home visitor feels prepared to address. If there are issues related to mental illness, severe postpartum mood disorders, there's a place that those families can be referred to where they can get a more intense level of service. So those things will be coming with the Alliance. We, as a member of the League of States, you will technically be also a member of the Alliance. We're kind of trying to transition our use of language away from League to Alliance. But you all will have, the way that we understand the board will work is that your association will have a vote on, have a representative to that board and have a vote in how that board becomes formed and the kinds of things that the Alliance do. But again, the primary purpose is really to support all of these states so that we can all be doing, implementing endorsement the same way from state to state in a meaningful way and supporting one another. The other thing that you might notice is there are some regional clusters. And we imagine one way that this may become more sustainable for associations is if they pool resources from time to time, whether that's sharing people who can review exams or co-sponsoring training that is in one region that people from maybe 3 different states could get to, that there be some natural sort of sharing of resources that might help the effort become more sustainable over time. All right, I want to talk just a little bit about what we know so far about the individual benefits of endorsement. One is this idea that we talked about before, that it's a map that can guide professional development. We were talking earlier, I came out of graduate school, I had my MSW, and I thought, okay, well, these people think that I know something. They gave me this piece of paper, and I'm going to go out there and I'm going to help families. And then you meet with your first family, and you leave there, and you go back to your office, and you think, those people need professional help. And then it slowly dawns on you, that's me. I'm a professional who's here to help the family. So through that process, I became very aware that I didn't know everything I needed to know to be helpful to families. But I didn't know what I didn't know. What is it that I need to know more about if I am going to be truly helpful to families? And so that's a part of what the competency guidelines can provide. What is it that you don't yet know that you really need to know? One of the things that we give every person at the beginning of their application process is something we call the Getting Started form. And really it's a self-study that allows an applicant to take a look at, okay, what courses have I taken? What in-service trainings have I attended? What experiences have I had that are related to those knowledge and skill areas? And then it illuminates where the gaps might be. Okay, so what is it I don't know? Maybe I need more about pregnancy, or maybe I need more about standardized screening and assessment tools. But at least there's a map that will help you sort of plot that out. Where am I strong and where do I need more? Once a state has adopted the competencies and the endorsement, it's been the case in every state so far, that they also have a commitment to provide the competency-based training that will help people achieve endorsement. So one of the individual benefits is often that there's more training available than there was before to choose from. Certainly in Michigan, access to reflective supervision and consultation has gone up. One of the things that, I mentioned how great and how lucky we've been to have infant mental health home visiting services in the community mental health system in Michigan in every county of the state. The bad news is that it was in every county of the state, and there were people in far-flung regions of the Upper Peninsula, of the thumb, of the pinky finger, that didn't have access to training and did not have access to reflective supervision. And a worry for all of us was that the model was being watered down. Without access to good competency-based training, without access to reflective supervision, was the infant mental health home visiting model really being carried out? So we're fortunate, and we'll talk about it a little later, Michigan now requires endorsement as a part of the Medicaid regulations. So far more people now do have access to reflective supervision than they did 5 years ago. So that's been a benefit. And then for the others, there are people who've chosen, they do want to specialize in infant mental health, and they have pursued the training, and they have pursued the education and the experiences, but they don't have a way to show that to the world. I've chosen this as my specialty, I'm committed to this, and so applying for endorsement is a way to document that I've done this. All right, next slide. So we don't yet have a lot of data about what difference it makes in terms of being endorsed, but we have a little bit. And I wanted to share with you some quotes from some of the folks who've been interviewed in Michigan about what endorsement, what they believe it has meant to them in terms of their own view or perception of infant mental health. I have a better understanding of the importance of this work. I'm well prepared for work with families. I obtained more relevant training and supervision than I would have otherwise. This is what I just mentioned before. The time spent preparing my application helped increase my understanding of infant mental health work. So again, that idea of looking at the competencies, whether you're doing a Getting Started form, self-study, or you're just examining as you prepare your own application, you become more aware of these are all elements of good best practice in terms of infant mental health. It's not enough that I understand about attachment, separation, trauma, grief, and loss. I also have to understand about development. I have to understand fully what attachment looks like when it's going well and when it's not going well. All of those aspects are important to good infant mental health practice. The material for the exam deepened my understanding. So we haven't talked yet much about the written exam, but there is a 3-hour exam that's expected for folks at level 3 and level 4. The first half of the exam is a multiple choice. Folks have 90 minutes to respond to 60 multiple choice questions. And then the second half of the exam is a response to vignettes. So folks, for instance, who are applying for infant mental health specialist level 3 would have clinical vignettes about an infant mental health practitioner and that person's relationship with the family and the circumstances of that family. And then they have an opportunity to respond to questions based on that vignette. So for level 3, they would respond to 2 vignettes total, so about 45 minutes each. But in terms of preparing for the exam, MI-AIM has put together what is probably maybe a little too comprehensive of a recommended reading list to help folks get ready for the exam. And so there are people as they're preparing for the exam and reading things that maybe they haven't read for 20 years or that they missed or is new, that process of just getting ready for the exam has improved their skills. And increased my credibility. This is a big one too. That if you're particularly in a courtroom, these programs in Michigan that I mentioned through the community mental health most are serving, I would say in some programs, it's 50% of their kids are child protective services or foster care involved families. And so those folks feel like they have some credibility to say to a judge or a referee or a child welfare worker, hey, this is what this baby needs based on the assessment that I've done of this family. These are the recommendations I'm making. And here's why I can say that with some certainty, because I've achieved this level of competence. Okay, and then professionals were asked also what they think the benefits of endorsement are to the families that they serve. And I thought this was really useful as well. I think it maximizes my capacity to be fully present with them. And that's one that I sort of attribute to the reflective supervision requirement. That when folks have a place where they can feel fully present to really think deeply about a family with someone, then they have the parallel process. Then that practitioner can go and really be fully present and think carefully with the family in hopes that that is going to then affect the way that the mom can really be present, or the mom or the dad or both of them can be present for that baby. I'm a more well-rounded clinician due to requirements for reflective supervision and continuing education. My knowledge and studies make me a better therapist. I'm a better advocate in court, and it's increased the breadth of knowledge and treatment approaches. So that's another thing that I think is really useful about the competency guidelines is there's a very wide breadth that we're expecting in terms of those 8 different competency domains, but it's the depth of what's expected that changes from level to level. Okay. In terms of system-wide benefits for folks in states that have adopted these competencies and this endorsement, there's been a lot more cross-systems collaboration. Once the endorsement has been launched in the state and there's a need for folks to have some competency-based training so that they can pursue endorsement, it's often resulted in people talking with one another across systems about training. So I think here in Washington, you've recently done a very extensive training survey to look what's already available, what's being provided to practitioners in our community, but also what's missing. So if there's something that is missing, there may be an opportunity for systems to collaborate with one another to bring that training, whether that's child welfare and mental health talking to one another and collaborating around providing a training, or early intervention and education. It's just been, we'll have some more specific examples about that later, but it's been one of the sort of unexpected benefits. It provides strategies to recognize the importance of workforce development for infant and family professionals. This is really sort of speaks to that, really trying to professionalize infant mental health as a field itself. It gives a lot of legitimacy when people can point to a set of competency standards and say that I've met these things, I've achieved competency in these levels. And there are a number of states who are using funds through the Affordable Care Act, through MI-AIMH, to adopt competency standards to try to make sure that the staff in each of those programs, in addition to the standardized training that they might receive as part of their evidence-based program, that they also might have gaps that could be filled by some infant mental health training to make each of them a more well-rounded practitioner. There are a number of university programs that have been designed or revised to be aligned with the competency guidelines, and I've got some examples of those I can show you in a second. And then endorsement has been linked to professional development requirements in some baby courts. Does Washington have any baby courts yet?
Yeah.
Susan.
We don't have a safe baby support team here in Houston.
Okay.
We have a couple of courts that have been cultivating slightly modified models of baby.
Okay. So for those of you who couldn't hear her, she was saying there are no 0 to 3 safe baby court teams that follow that model, but there are others who are sort of adopting or adapting a model similar to that to form a sort of a baby court in the community. And that's true in Michigan as well. And in some of those baby courts, the judges have been educated about the competencies and about the endorsement and have said, I only want folks on this team who are endorsed at level 3, or I won't take testimony from someone unless they're endorsed at level 2. The other thing is that folks, when it's not an identified specialized baby court, but it's still a child welfare proceedings involving a baby, is that folks have been able to use their endorsement to be qualified as an expert witness, which then allows for a very different level of testimony that can be provided in that courtroom. Okay, so I want to give you just some examples of the ways that competencies are being used to develop training in different places. Oh, I'm sorry. I was going to do it, but I forgot Sheryl.
So we have some pretty exciting opportunities that have come our way in terms of trying to partner with folks who are doing training and our own development of training models, as well as gaining grants for training series that could focus on particular areas we want to grow. What you have up on this slide is actually a training model that Tulane University asked us to work with them on. We spoke, they were interested in developing some online course that was particularly relevant for those who are seeking endorsement. And as we discussed things over time, it became evident that what we really needed was something that was really tailored to the clinician who's out there who is working toward level 3. And that there were some other opportunities through other online courses that could be, they were already available. SEED being one of them for folks who might be focusing on more general home visiting. So we worked with them, and they particularly aligned with our competencies. What looks like a 2-part course. This first part is put up there, and that is 15 hours that is particularly focused actually on assessment. And it is, again, it's going to be very interactive, so there are lecturettes, there are discussions, there are assessment kinds of things, there are videos. It will be a great series, and it's going to be rolled out later this year. Then they'll be referring people back to their local mental health associations for more specific reflective supervision that qualifies them for endorsement and for further consultation. You can engage with the faculty there for some consultation should you choose to do so. But the second part, which is not up on this slide, that they will then start working on after this is rolled out, will be focusing more on treatment. And that'll be another 15 credit hours. And we're pretty excited about it, that they've really worked with us, they've vetted with us, and are continuing to do so. We wanted to give you a couple examples then of training that was intended to build capacity for reflective supervision. One model that we developed and delivered in Michigan was funded by the Ethel and James Flynn Foundation, and this consisted of two series of half-day presentations. The first of the 4 half days were delivered 1 month at a time, and that was specific to supervisors. And this was focused on our largest supervisory cohort in the Metro Detroit area. That is who the Flynn Foundation likes to support. And it is probably our largest infant mental health. It is our largest infant mental health workforce in Michigan, and probably anywhere. So we had 16 supervisors who participated. in this training. And you can see some of the particular things we did. So there were little didactic lecturettes that addressed these topical issues, and we had live demonstrations with discussion and processing of supervisory experiences. And then in part 2, each of these supervisors brought into the session a supervisee. A couple of them brought 2 supervisees. And that was intended to really focus on supporting the relationship, supporting them working with each other, because we know it takes 2 to tango, right? You can be a great supervisor, but you have to have a partner who's willing to be engaged in that relationship with you. So it was the same kind of model as far as some didactic material. We talked about the development of the supervisory relationship, etc. And then we had these dyads, some of whom, 4 of them, were able to present in a fishbowl kind of situation with me. I was one of the trainers, and Doug Davies, who you might be familiar with, he was the other, and we developed, and we were the sort of facilitators of the processing of what we saw. So that is being evaluated right now. And there's some follow-up evaluation going on for that as well. Another model on training to develop providers for reflective supervision. Wisconsin, their Association for Infant Mental Health. They developed a model for their MI-AIMH programs, and this was a statewide collaborative project within those programs, along with the University of Wisconsin Infant Early Childhood Family Mental Health Capstone Program. And again, this was one of their methods to try and build capacity, increase the availability of qualified infant mental health consultants. So they had reflective supervision groups for their home visiting staff that were co-facilitated by an infant mental health mentor endorsed at level 4C and what they called a consultant in training. So those 2 folks would work with a particular group. And then the consultant in training also received individual reflective supervision consultation from the mentor. And then those consultants in training offered reflective supervision and consultation to the home visiting program supervisors. So these multiple levels of relationship support. We also have had, which I don't have a slide for, but we've also strived to integrate reflective supervision consultation components into other training series that we're doing. And we're actually on our 3rd go-round of another training series, which is connected to our competencies, funded by the Ethel Flynn Foundation again. But we also, in this 3rd training series, have support from our Michigan Department of Community Health for those who are outside of the Metro Detroit area. And so these 25 clinicians have participated in 8 sessions or 10 sessions actually, over the course of a year, once a month, 4 hours of training that's connected to all our competencies, and each of the totaling then 40 hours of training. And then each of those months we had 2-hour reflective supervision sessions according that were in alignment with the particular competency areas, where people were asked to bring a case to talk about. So that means a total of 60 hours. There are CEUs that they got, reflective supervision, and the training. And so we built that in for, for now, I don't know how many, it probably would have been 50, 60 people who have been through that at a minimum. That's just with the 2 that were focused on the mental health community. That was also adapted by our Great Start in the northern part of Michigan, and that was to a wider community, and they had asked us to also tweak that for the early care and education community up there. So I can talk more about that at another time if you have questions, but it's pretty interesting because one of our outcomes for that, in addition to pre-post for all of those series, has also been success on completing the endorsement exam. And we've got a great rate of success. So it's built competency and confidence for people in their professional development. And then, of course, we do have some shorter awareness level and sort of deepening level opportunities as best you can do for folks who do need to get their 3 hours of continuing education specific to the provision of reflective supervision, or who just need to learn about what is this reflective supervision thing. The next slide. I'm losing my tag here. Okay, the next slide that's training related, focused on early education and child welfare. In Texas, their largest group of folks really that TAIM has been involved with are the early care and education folks. They are also very lucky to have some very supportive foundations. And so they were able to get from the Hawk Foundation a training grant that covered infant and young child development and behavior, infant, young child, and family-centered practice, relationship-focused practice, the attachment, separation, trauma, and loss competency, cultural competency, disorders of early childhood, reflection, ethical practice, and advocacy. That's all. Anyway, that was delivered to child welfare and early care and education providers. Another more recent development, WA-AIMH, that's the Rhode Island Infant Mental Health Association, thanks to Susan Dickstein, who's one of their leaders, and her collaboration with Bradley Hospital, has developed a 16-hour, 3-section online course that has addresses these particular competencies that are listed up there. So I want to take a couple minutes and talk about what Nichole has actually spoken to for a minute, some of the other service delivery system changes. This first one, this whole Michigan Medicaid piece is huge. We never expected that, but we're totally thrilled and are so glad that our advocacy efforts and our communication with our state partners led to something that supported this, ability to really ensure that folks who are out there doing the work had the support they need and the information they need to do the work. They could only mandate a minimum infant family specialist, that's a level 2. But it is preferred that infant mental health specialists, level 3, be attained within the community mental health system. And some of the community mental health agencies are actually increasing their level of pay to go along with achieving that higher level of endorsement. And then New Mexico is another state. Their behavioral health department is quite supportive, and they are requiring endorsement for reimbursement for infant mental health services as well. Those are pretty big system changes. On my final slide, I wanted to speak a little bit more about some of the examples of higher education changes that we've talked about a little bit. In Wisconsin, the University of Wisconsin Infant, Early Childhood, and Family Mental Health Capstone Program. It was developed and in alignment with our competencies. It was established to provide intensive year-long training that includes reflective experiences. Dr. Roseanne Clark is a key leader in that effort. University of Minnesota, as we've talked about, their SEED, Center for Early Education and Development online courses. Some of those were tweaked to align, and the newer ones as they've developed have been developed with the competencies in mind. Arizona State University has a graduate degree in infant family practice, and part of their requirement for someone at the end of the program is to have prepared an endorsement application, which is a pretty creative way to do that. And then Wayne State University back in Michigan, we have a Merrill Palmer Skillman Institute, and they have a dual title program in infant mental health, along with social work, MSW or PhD, or nursing, which is a PhD level, and early childhood education at the master's level. So there's lots of stuff happening. Those are only some of the examples. These are highlights, and we have shared with Nina and some of your leaders more detailed reports of what states have done in these areas of training, collaboration, system change, funding, sustainability, etc. So all that information is available to you and can be shared. So I think I would just say in closing, before we turn this back over to Stacy, and then address your questions, that we never imagined the incredible impact that our ideas would have those many years ago when we worked for those 8 years just to put this together. And then when we first rolled it out, and the interest within a few years from our first state, which was Texas, to purchase a license to use this. But now we can imagine so many more possibilities as we share the experience of synergy and being involved with you and our other league partners in the future. So thank you so much. We are really looking forward to working with you.
But I do also want to mention that right here in our mighty state, there's a lot of training happening, and I wanted to mention in particular the Barnard Center for Infant Mental Health and Development, because that's a graduate level program that people can go through, get a certificate, and all of their coursework is aligned with the competencies. So if you don't know about that, Sue Speaker, our board chair, is the director of that program, or you could talk to her, you could go online and find out more about it. But that's one excellent way to get some of the training that